All right, I'll go ahead and get started. So today our seminar speaker is Dr. Shaneda Warren Anderson, and Dr. Anderson is an assistant professor of population health sciences in the School of Medicine and Public Health at the University of Wisconsin-Madison. She's a cancer epidemiologist, and she is interested in how social determinants, modifiable risk factors, and molecular factors work in concert to influence cancer risk and survivorship. She is particularly interested in achieving health equity in colorectal cancer for vulnerable subpopulations who are less likely to undergo colorectal cancer screening. For example, African Americans, individuals of low socioeconomic status, and adults under the age of 50. So Dr. Anderson's research interests build upon her previous training. She received her BS in genetics from the University of Wisconsin-Madison and later earned an MS and PhD in population health from the University of Wisconsin School of Medicine and Public Health. She completed her postdoctoral fellowship at Vanderbilt University Medical Center's R25 Molecular and Genetic Epidemiology Cancer Training Program, and then she joined as faculty there. In 2018, she returned to the University of Madison as faculty as an assistant professor of population health sciences. She is also the faculty director of their Survey of Health of Wisconsin shared resource. Dr. Anderson's research program uses molecular epidemiologic methods to identify determinants of cancer risk and survivorship. Dr. Anderson's research program investigates how differences in the distribution of important tumor characteristics, access to healthcare, and modifiable lifestyle factors may contribute to disparities in colorectal cancer outcomes across populations. And just one more little side thing I want to say about her. My postdoc mentor at Vanderbilt also worked with Dr. Anderson, and he told me that she was phenomenal. He said it in such a way I got jealous, actually. He says there are few people like her. So just a heads up. I think you had an K99 ROO, didn't you?
Yeah, I did, yeah.
Yes. So, okay, So I'll hand it over to you.
Oh, well, that's such a nice introduction. I think that's enough. We can be done. But yes, thank you for that introduction. And so, right, as Rebecca said, I'm a cancer epidemiologist, and so I'll be talking to you today about cancer. And so this slide has a few outline and objectives that we'll be going through for the next hour or so. So we'll start off talking about cancer and how it's such a large burden in the United States when we think about morbidity and mortality. And we'll talk about some established risk factors and prognostic factors that have been identified over the years. Then we'll talk more about cancer screening and how it prevents cancers and can increase survival, but how even with cancer screening, we still see disparities in the cancer burden that's experienced. Specifically, we'll talk about socioeconomic status and racial disparities. And to do that, we'll use colorectal cancer as an example. So we'll talk about colorectal cancer screening and some risk factors and prognostic factors that we have been established and also are emerging in the field. And then lastly, we'll just kind of follow up with some conclusions about cancer outcomes and how they're strongly influenced by lifestyle factors, social determinants, and access to healthcare. Okay, so to start off, we'll talk about cancer incidence. And so when we're talking about that, we're talking about the number of individuals with a newly diagnosed cancer, so their first cancer at that site or in their lifetime during a specific time period. And so on this slide, I'm showing some data from the American Cancer Society. They have tabulated some estimated cancer incidence numbers for the United States for 2023. And this is stratified by sex. And so on the left-hand side of the slide, we see the percentages and also the number of individuals that'll be diagnosed with specific cancer sites among men. And on the right side, we see the same, but among females. And so a few things to kind of pick out of this slide. One, just the magnitude of the number of people that'll be diagnosed with a new cancer in this year alone. So we're talking about almost 2 million cancers. We can see that men are more often diagnosed than women. And then there are certain cancers that are frequently diagnosed, prostate and breast among men and then women. But when we combine sexes, we see high cancer incidence of lung cancer and then also colon and rectal cancer. This slide shows data, again, from the American Cancer Society, and it's showing cancer trends in the United States, starting in the 1975, going all the way until 2017, stratified by race and sex. And so a few things to note here. One is that when we look at the top line, which represents cancer incidence among Black males, we can see for the entire period, Black males have been the grouping that have had the highest cancer incidence rates compared to all the other groups that are displayed here. We can also see that among Black females, we see lower cancer incidence, but it's pretty close among close to white females. We don't really see the same racial disparity there, but we will say that trends have been consistent over time. This slide shows similar data, but now we're also including data by ethnicity. So at the very end, we see Hispanic ethnicity, and we also see a few other racial groups displayed here. I've included this to just show that for most of the racial and ethnic groups that we see here, that men are diagnosed more often than women. And then also to just highlight that for Black males, we see that, again, this is the grouping that has the highest cancer incidence rates among all races and ethnicities and sex groups that are included here. So really just highlighting this consistent disparity by race and also a little bit by sex. And so throughout the years, there have been a number of risk factors that have been identified for overall cancer incidence. One that's a strong risk factor is age. So cancer is mainly a disease of older age, but we also know there are other risk factors that have been identified to be consistently associated with either increased or decreased risk of cancer. One would be a family history, also some genetic predisposition to cancer. We also know that there are lifestyle factors and body weight. So there are certain health habits that are related to lower cancer incidence or higher cancer incidence. We can think about environmental exposure. So we can think about things like pollutants, but we can also think about social factors as things that are environmental factors. So thinking about things like race, socioeconomic status, access, all these things influence risk to cancer overall. And then we know there are a number of hormonal exposures that contribute to cancer, specifically when we think about prostate and breast cancer. Hormonal exposures can be associated with increasing our risk for those. So for this next section of the talk, we're going to talk specifically about lifestyle and body weight and how that's related to overall cancer incidence. So there are several experts groupings that can make guidelines and recommendations related to how individuals can lower their risk to cancer. We can think about things like expert panels that make recommendations for cancer screening. So those are usually based on age or family history. But there are also two different organizations that make guidelines for cancer prevention that are based primarily on epidemiologic evidence about lifestyle. So these groupings are the American Cancer Society and also the World Cancer Research Fund, American Institute for Cancer Research. So it's a combined grouping and they, as a group, make recommendations about lifestyle. And so these expert recommendations consistently outline expectations for health behaviors that people can do around things like nutrition and diet, exercise, tobacco, alcohol, and then weight and weight gain as an adult. And if the idea is that if people follow these guidelines, they'll be at lower risk of developing cancer overall. So we'll talk specifically about the American Cancer Society and the guidelines that they have outlined for how a healthy lifestyle can reduce cancer risk. And so how the American Cancer Society comes up with these guidelines is they convene an expert panel of experts that are interested in cancer research, prevention, epidemiology, public health. And this grouping reviews the most recent evidence, typically epidemiologic evidence, related to things like diet and activity. And after they review this evidence, then they make recommendations for individual choice for diet, physical activity, body weight. And then recently they've begun to also make recommendations that can be implemented at the community level and how communities can facilitate individuals having healthy behaviors. And so project that we did in the Southern Community Cohort Study was to use data from this prospective cohort study to evaluate whether adhering to these cancer prevention guidelines was actually related to lower cancer incidence, using data from this prospective cohort study of low income and primarily African American participants. And to do that, we created a 5-point scale related to these American Cancer Society guidelines. And so I'll talk a little bit more about the data set here and also how we achieved this, creating this score. So as I said, we used data from the Southern Community Cohort Study. This is a prospective cohort study of over 85,000 adults that were all recruited from 12 southeastern states. So over in the, yeah, you can see my mouse. Over in the corner here, these are the states that were included in the Southern Community Cohort Study during recruitment. At enrollment, participants were aged 40 to 79, and everyone completed interviews on demographic characteristics, lifestyle factors, medical history. This all was done between the years of 2002 and 2009. Participants were recruited from community health centers, and these are medical centers that primarily serve underinsured or underinsured individuals. And so this is one thing that makes the Southern Community Cohort Study different than other large-scale cohort studies, is that it really includes a lot of participants that are of lower socioeconomic status, primarily due to how the participants were recruited. So then an additional 14% of the participants were recruited from the general population through identical mailed questionnaires. And so in that way, there have been a number of participants that were enrolled that have higher socioeconomic status, and so we can make comparisons between lower and higher socioeconomic status within the cohort. A little bit of information on characteristics. Approximately 2/3 of the participants are African American, and at baseline, 55% of participants had a household income less than $15,000 per year, and about 61% of the participants had educational attainment of a high school education or less. And so this is really showing how this cohort is different than a lot of the other large-scale cohorts, especially cancer cohorts. And so this study was conducted as a resource to conduct studies and interventions to identify, reduce, and eliminate cancer health disparities. So how we created the American Cancer Society score was to sum the number of health behaviors or lifestyle factors that a participant adhered to when looking at the guidelines for nutrition and physical activity. And so when we created the score, a participant was assigned 1 point for having a BMI that was in the normal or average weight category, meeting the physical activity guidelines for Americans, meeting at least 2 sub-guidelines for an American Cancer Society diet quality score, and being a non or moderate alcohol drinker. We also conducted sensitivity analyses among participants without a chronic disease at baseline, and this would include participants who did not have diabetes, hypertension, or COPD. And we did this because we wanted to identify what the association between healthy lifestyle was and cancer risk among people that didn't kind of have other comorbidities that might be influencing their cancer risk. So here are some data on the slide to kind of orient ourselves to the slide here. We have the number of guidelines met with 0 as the reference category. And then we have the total analytic population. And then we also have our participants where we conducted the sensitivity analysis of people without chronic disease. So when we start here and we look kind of at people that the total analytic population, we do see hints of an association where people that met more guidelines were at decreased risk of cancer incidence overall. But I think where we see the most interesting finding is where we look at participants without chronic disease at baseline. And when we look among these participants, we see a stronger association where people that meet more healthy guidelines are related to having lower overall cancer incidence. And so we looked at individuals that had, we looked at all cancers combined, and then we also looked at incidence cancers excluding lung cancer. And we did that because smoking is so strongly related to lung cancer that we wanted to see if we're not looking among a cancer site where we know kind of the strongest risk factor, do we still see these associations? And you can see that we do. We still see significant trends when we look at all incident cancers and we look at incident cancers excluding lung cancer. And so our guidelines score does not include smoking. And so we did do sensitivity analyses where we looked among cases stratified by smoking status. And so just really quickly here, this is the same results, except now looking among never or former smokers, and we see similar trends. And then we also did it among current smokers, and we also see similar trends. So as I mentioned before, in addition to talking about what individuals can do in terms of lowering their cancer risk, the American Cancer Society also makes recommendations that can be implemented at the community level to reduce cancer risk. And so here I'm just providing some information as to what those recommendations are. And basically what they're highlighting here is that it's important to make it accessible for people to be able to do these healthy behaviors. So increase access to affordable healthy foods, make it easier for people to participate in physical activities, both at school, workplaces, and in their home environment. So we think it's important to emphasize both individual action, but also the structural pieces that are necessary for people to actually do the individual health behaviors. So to summarize this section, what I'm showing here is that adhering to health behaviors around diet quality, physical activity, alcohol intake, smoking, and a healthy body weight can reduce individuals' risk to overall cancer, but it's important to acknowledge that there are structural pieces in place that need to be put in place to adhere to making these lifestyle choices achievable. All right, so switching gears just a bit now, we've talked about cancer incidence, so talking more specifically now about cancer mortality. We will kind of discuss the burden of cancer overall, thinking about mortality. So this slide shows data from NCHS that shows the top 10 causes of death in the United States. And there are a few things to note here. This is showing data from 2020 and also 2021. So the most recent data that's available is we see for both years, cancer is the second leading cause of death. And we can also see that it accounts for about 20% of US deaths. And this is something that's been consistent over several years. But this slide just goes to show really the magnitude of burden, both in terms of incidence, but also mortality of this disease. And then this slide is similar to what we saw for cancer incidence, but now we're looking at among cancer death in the United States, estimated numbers for this year alone. And so we see some of the same cancer sites are strong causes of cancer death as they were for cancer incidence, but we do see some differences. So lung cancer was the second most commonly diagnosed cancer, but it is the most commonly cause of death among both men and women. And so this really, again, is showing the magnitude of what smoking can do and how deadly lung cancer is at this point. And we also see colon and rectal cancer, again, as the third most deadly cancer in the United States at this point. So this slide shows trends in 5-year relative survival rates from 1975 until 2018. At the top, we see all sites combined, but then lower we see the overall survival rates for different anatomic sites. And so this slide shows a few different things. One is that if we look at trends from the late 70s until more recently, we see overall that we see increased survival rates for all sites, and then also for a lot of the different specific sites in general. So this shows that we are increasing survival, and we know that that's due to a few things. One, it's due to increased cancer screening rates, and it's also related to better treatments that have been identified over the last 40 or so years. However, even with these increases in relative survival rates, we still see disparities. And so we see here 5-year relative survival rates, again, for all sites, and then by different anatomic sites. But now we're stratified by race, and we see non-Hispanic white versus non-Hispanic Black rates. And at the very end, we see this absolute difference. And so I've included this slide to highlight that although we've seen a lot of improvements in survival over the last 40 or so years, we're still seeing disparities. And one thing that is important to note is that we see disparities among cancers where we have screening, which we think would be the most preventable types of cancer. And so we have large-scale screening programs for specifically for breast, colorectal, lung, and cervical cancer. And so when we go back to that slide now and we look among these cancer sites where we can see that there are screening in place, we still see absolute racial differences. And I haven't shown data yet by socioeconomic status, but we would also see these types of differences in relative survival if we looked among socioeconomic status as well. So this is showing that we still have work to do in terms of how we can increase survival overall, but also when we look around among certain subgroups. And so now we'll kind of move into talking specifically about colon and rectal cancer as an example. So this slide shows long-term incidence and mortality stratified by race and ethnicity for colon and rectal cancer. So if we look at the top of the slide, this is showing colon and rectal cancer incidence among Black, white, and then Hispanic Americans. And at the lower levels, we're seeing mortality. So Black, white, Hispanic. And so this slide shows a few things. As expected, incidence is much higher than mortality for colon and rectal cancer, but we can see that there have been longstanding disparities in terms of both incidence and mortality. And this really started to occur in the 80s, where we see higher incidence among Black Americans than other racial and ethnic groups. And we also see worse mortality among Black Americans compared to other races and ethnic groups. So a little bit of information about colon and rectal cancer. Colon and rectal cancer is the second leading cause of cancer death in the United States. So when we stratify by sex, it's the third leading cause, but when we combine, we see second leading cause. We can see that rates differ by race, where African Americans have 40% higher mortality than non-Hispanic white Americans. And we know there are some differences. We know some of the reasons why there are differences in survival. We know some of it is related to screening rates. We also know there's differences in lifestyle factors in terms of the prevalence of these healthy behaviors that I discussed earlier. There's also differences in access and barriers to resources such as healthcare and screening. There's differences in the amount of treatment and the quality of treatment that occurs by race. Then there's also a little bit of evidence that there can be some differences in tumors, the aggressiveness of tumors by race. And so for the next section of the talk, I'm going to talk a little bit about screening rates and how that can contribute to survival, specifically thinking about colon and rectal cancer. So when we think about cancer screening, the most important group would be the United States Preventive Services Task Force. And this is a task force which is a group of experts that are convened, and these are experts in prevention and evidence-based medicine. And why they come together is so that they can make recommendations related to different preventative services. We'll talk specifically about cancer screening. And so what they do is they consider the costs and benefits of a screening service, and then they give a grade based on their recommendation of this, if this should be used at the population level. And why this is important is because depending on the grade that the USPSTF gives different services, different cancer screenings, that will decide whether Medicare will waive a copay and also whether insurance will kind of pay for or support their members receiving the cancer screening. So it can be really important to align with these grades, because this will kind of affect whether people have access to the cancer screenings or not. And so when we think about colon and rectal cancer screening, I think a little bit of a primer on the anatomy and formation of how these cancers form can be useful. So here we see the where the colon and the rectum are in the body, and then also all the way to the right, we see a schematic of how colon and rectal cancers are formed in the body. So these cancers typically form as a polyp or an adenoma in the colon, and these can be visible upon cancer screening. And then eventually the polyp can grow into the inner lining of the colon and rectum, and eventually spread to other parts of the organ, to lymph nodes, and then eventually metastasize to other parts of the body. And so why this is important is because we know how colon and rectal cancers are formed. We can intervene at any point of that progression to remove the polyps or cancers, and either we can remove the polyps before they form as invasive cancers, or anywhere in that progression, with the idea that early detection will lead to increased survival. And so on this slide, I've shown in the colon what different kind of levels of adenoma, advanced adenoma, and then invasive cancer would look like. And in a colonoscopy, any one of these formations could be removed, and that should increase an individual's likelihood for survival. So there are a few different types of colon and rectal cancer screening. They're based either on visual or stool-based. And so a visual-based screening modality would be something like a colonoscopy. This is where we can take images, or through a scope, visualize the colon and the rectum and look for polyps or cancers in the body. There are also stool-based screening modalities. And so these are tests that are done on stool, and the tests are looking for and trying to detect either blood or DNA from a colon and rectal cancer. It's important to know that these stool-based modalities are less invasive, but they must be done more often. And they can't identify cancers as well as a visual-based screening mechanism. So we know that that colon and rectal cancer screening should increase survival and prevent cancers. But we know that there are disparities in who is getting colon and rectal cancer screening. So this slide shows prevalence of colon and rectal cancer screening stratified by both age and race and ethnicity. And so it's important to note here that we see that we have higher colorectal cancer screening in older age groups, but also that we see differences in colorectal cancer screening rates by race and ethnicity, where Black, Hispanic, and Asian individuals are less likely to be screened than non-Hispanic white individuals. In addition to differences by race and ethnicity, we also see differences in colon and rectal cancer screening by insurance status. And that gets back to what I was talking about earlier with recommendations that are made. So if there are screening mechanisms that are not covered by insurance, people are less likely to get them. And also, if people don't have insurance, are less likely to get them because of the cost out of pocket. So this is showing, again, prevalence of colorectal cancer screening. This is among adults older than age 50. And we can just really see this disparity in terms of people that are insured versus uninsured as to whether they have had, if they're up to date with their colon and rectal cancer screening. We can also see differences in colon and rectal cancer screening by state. And so it's pretty small here, but here, this is every state in the union listed, and we can just see that there are differences in the prevalence of adults who are up to date in their colon and rectal cancer screening. And so at the state level, when we see these geographic differences, they're based on a number of things: demographics of the state, but also health insurance access and uptake, and then access to colorectal cancer screening, especially colonoscopy, can vary based on demographics of the state and the types of providers that are available to the people in the state. And so again, getting at why is this important? Well, we know that colorectal cancer screening is related to the stage that a cancer would be found and detected, and that leads to survival rates. So at the top here, this is showing the percentage of cases that are diagnosed at each stage, where localized is in this dark green color, and this would be kind of the less invasive cancers compared to distant here, and unknown. Unknown is a smaller grouping. So we just see this is the distribution of how cases are found and detected. And then if we see lower, we can see that there are really differences here by 5-year relative survival, where people that are diagnosed at localized stage have much higher survival than someone that would be diagnosed at this distant stage. And so we did a study in the Southern Community Court study looking at this as well. And so we looked at whether ever use of lower endoscopy, which we included colonoscopy or sigmoidoscopy, whether that was associated with lower risk of dying of colon and rectal cancer. And so as expected, we see, compared to people that have never participated in lower endoscopy, individuals who have ever done screening are at much lower risk of dying of colon and rectal cancer. And so this is something that was, somewhat expected, but just goes to show how important screening can be for lowering risk for colon and rectal cancer mortality. So we know that colon and rectal cancer screening is important for outcomes, both incidence and mortality, but there are major challenges to colon and rectal cancer screening. So we talked a little bit about this earlier when we think about stool tests. The way that these tests are set up, they're really detecting blood or DNA after a tumor has already formed. And so it's not so much of a preventative test, more of an early detection test, which is important, but it is important to note that there is a difference there. These tests are often preferred by individuals because they are so much less invasive and time consuming, but they are not as effective as a test like a colonoscopy. However, there are a lot of challenges to participating in colonoscopy. I think anyone who's ever done one will admit that the prep is unpleasant to say the least. It's also time intensive. And so that can really introduce barriers to its use, especially the time piece. So someone has to be in the position where they can take time off of work, arrange childcare, arrange for transportation to and from. And so these are just additional barriers for getting people invested in colonoscopy. An additional barrier that's more structural is at this point, if everyone that's eligible for colorectal cancer screening were to decide to get a colonoscopy, we simply don't have enough people trained to actually do the procedure. And so that's a huge barrier at the system level that needs to be addressed. And then something that we also need to address is that there can be serious complications related to colonoscopy. They're very rare, but it's more than non-existent. And also, if someone is in a place where they would be interacting with a gastroenterologist that doesn't have as much experience, it's not of higher quality, you'd be more likely to see these rare but serious complications. So these are major challenges to the use of colon and rectal cancer screening that should be acknowledged. And so we know that there are big barriers. And when we looked at who is getting screened and looked at demographic and socioeconomic status factors, we did see differences. And some of that is related to the structural challenges to colon and rectal cancer screening. So when we looked at ever participation in lower endoscopy at baseline interview of the Southern Community Cohort study, we see differences by sex, race, educational level, income, insurance status, and also smoking status. And in each one of these situations, people that we know are at increased risk, so of Black race, lower education, lower income, uninsured, smoking, they were less likely to have ever participated in screening. So really outlining that colon and rectal cancer screening is effective and can prevent cancer and increase survival, but we're not necessarily reaching the people that are at the highest risk for colon and rectal cancer incidence and mortality. So there are some solutions as to how to overcome some of these challenges in colorectal cancer screening. One would be to train rural surgeons or other providers to do colonoscopy, so that could help at the system level to have more people that can do the screening, if there is a need for it, and there is. And then also just highlighting that the best colorectal cancer screening test is the one that gets used. So often epidemiologists and researchers, we focus on colonoscopy because it really is kind of the gold standard. But if we can't get people to use that, we really shouldn't discount the use of stool tests. They are a good tool for people that are reluctant or don't have access to colonoscopy. I'd say the biggest barrier there is just they need to be done more often than a colonoscopy. And then when we're thinking about other solutions to the challenges, we should be thinking about multi-level interventions. So thinking about at the patient level, the provider level, and then also thinking about health systems. So thinking about reminders, an electronic health record, or thinking about things like arranging transportation to and from a colonoscopy visit for our patients. All right, so summarizing kind of what we went here, that we've seen that there have been major increases in survival rates among Americans in the last 30 to 40 years, and a lot of that has to do with screening and also treatment. But we have to acknowledge that these advances in screening have also been accompanied by racial and socioeconomic disparities. And these are really related to the structural issues with achieving up-to-date cancer screening. And so when we think about new technologies like things like Cologuard, it can't overshadow structural barriers to health and how important those are to people's outcomes. And when we think about these differences in colon and rectal cancer screening, we can see how clearly they contribute to documented disparities in colorectal cancer incidence and survival. And then just briefly, I was going to talk about a new project that we're working on thinking about tumor differences. So we've talked about differences in survival related to screening rates, and a lot of that's related to access and barriers to resources. We've talked about lifestyle factors, and then just briefly to end talking about tumor differences. So as I said earlier, there's some evidence that there could be some molecular features that are related to aggressiveness of the tumors that contribute to racial disparities in colorectal cancer mortality. And so I'm just starting a new project where we're going to be looking at gene expression patterns, both among Black participants, but also non-Hispanic white participants of the Southern Community Cohort study. So we'll be looking at gene expression patterns of the colon and rectal cancer tumors themselves. We'll also be using data from the Black Women's Health Study. So we'll measure these gene expression patterns, and then we'll evaluate whether they are different by race and whether those differences contribute to mortality. And we'll be doing that all while accounting for receipt of colorectal cancer screening and then also treatment. So on the right-hand side, I just have a few basic demographics of the Southern Community Cohort study, but also the Black Women's Health Study, because these are the two groups that we'll be using to fulfill these aims. And on this slide, I'm showing kind of a conceptual model that we came up when we think about differences by race for colorectal cancer screening, and just kind of the motivation behind doing a study like this is to really try to promote health equity among all different types of racial groups, thinking about how important it is to include different racial groups, just so that when we are creating things like colon and rectal cancer treatments that are related to gene expression, to make sure that everyone is involved in that, so that these treatments are applicable to all different types of tumors. So I think I'm just a little bit before 12:42, but I have just a conclusion slide, and then we have time for questions. So, or a little bit before 12:45, I should say. So what we talked about today, we talked about that cancer is a large burden in the United States by morbidity and mortality standpoints. We talked about established risk and prognostic factors, and how the difference is there's differences in risk and prognostic factors by race and socioeconomic status. We know that widespread population-based screening lowers cancer risk. It also increases survival, but disparities exist by socioeconomic status, race, and other factors. And we used colorectal cancer as an example to display, how those things happen and how these disparities play out. So in conclusion, cancer outcomes are influenced by a healthy lifestyle and also social determinants, thinking about things like race, socioeconomic status, and access and use of healthcare. On this slide, I'd just like to acknowledge all of my co-authors and colleagues that were included in these papers and manuscripts, and then also the American Cancer Society for a number of the slides that I used, and then also my funding sources. So yeah, I have more information that I could talk about, but I also would welcome questions.
Quick question. So the data for the people who identify as Hispanic seemed a little bit paradoxical, considering they didn't have high screening levels, but they also had the lowest incident and mortality rate for colorectal cancer, if I'm remembering the slide correctly. Are there any theories about some protective factor that they may be exposed to or experiencing?
Let me see if I can find the slide.
It was the one that had the time trends for Black, white, and Hispanic. Yeah. I mean, that's a much lower mortality rate for a group that's not being screened, right? So it's kind of stands out. Yeah,
so the Hispanic data is a little different. Yeah, I didn't talk much about that. So there can be issues with this type of tabulation of the Hispanic ethnicity, because it includes so many different ethnic groups into one kind of overall group. And so I think it can be hard to interpret the data. So I don't think I'm willing to interpret it, but if there's someone else that would want to, I'd be glad to hear someone else's ideas.
I was hoping it was capsaicin, because then we could all just eat more spicy food, but I don't know.
Yeah, I have not heard that, but.
So I have a question. I know in some places they have things like in West Virginia, they have Bonnie's Bus, and to encourage screening for breast cancer to people who are less likely to come in for screening, or because of it's not easy for them to get to the place. So they have something similar, and in some places, I guess breast cancer screening or mammogram is free, or at least if you have insurance, it's free. What about for colorectal cancer?
Yeah, there are a lot of different programs, and some of it is dependent on the state. So, we see those different levels of screening based on location. It can also be based on health systems and just different initiatives. So, usually the kind of outreach screening would be a stool-based test. So these are relatively inexpensive and also can be mailed to individuals' houses. So it can be easy to mail someone a test and they can mail back. And so that can be a way to increase colon and rectal cancer screening. The biggest issue with these types of outreach programs is that if someone has a positive stool test, they still need to get a colonoscopy done. And this now it wouldn't be a screening test, it'd be a diagnostic test, which can have implications for costs of insurance and how people are reimbursed. And also it just, again, gets back to those system level barriers. So it's sort of a two-step process with colon and rectal cancer screening. First, people would usually get a stool test when we're trying to get these harder to reach populations, but then we still have to find, we still have to organize them to get a colonoscopy for a diagnostic test. And also, I think a lot of it just comes down to time and reimbursement when it comes to that. And also, it is a relatively uncomfortable test. And so I think sometimes people are just really more hesitant for that.
Are there any other questions for Dr. Anderson? Warren Anderson? Well, I think it was a very informative presentation. You encouraged me to go get screened.
Good. That's good to hear.
Any other questions? Well, thank you so much. I really appreciate it. You being willing to speak to us today, and I wish you continued success in what you're doing.
Thank you. Thanks so much for having me.
Great. Take care. Bye.
Thanks. You too.
Dan says, thanks. Have a great week.
Thanks. You too.
Bye-bye.
Bye.